Anti-epileptic drugs basically are the drugs that are used to control seizure. Now what are seizures? Anyone? Abnormal electrical discharge in the brain. And what do we mean by convulsion? Actually, seizure is an abnormal electrical discharge in the brain, and convulsion is the manifestation of it, manifested by motor symptoms or sensory symptom or both. Okay. Now coming to epilepsy, these are the group of central nervous system disorder characterized by paroxysmal cerebral dysrhythmia manifesting as brief episodes called seizures, and accompanied by loss or disturbance of consciousness with or without characteristic body movement called convulsions, sensory or psychiatric phenomena. Now these are very unpredictable. একটা patient যদি epilepsy দিয়ে ভোগে, the episode between the two seizure episode or the convulsion episode may vary. So the frequency is unpredictable and highly variable. Focal origin in brain manifest depend on the site of locus regions into which discharge is spread and post-ictal depression of this region. যে জায়গা দিয়ে ফোকাসটা তৈরি হচ্ছে, like in case of thalamus the sensory symptom will predominate. So যে জায়গায় seizure or the locus of discharge is there, the manifestation will depend on that. That is why it is saying it's focal in origin, manifestation depend on the site of focus region into which the discharge is spread and post-ictal depression. Most of the cases of epilepsy are primary. When we look for the causes of epilepsy, the first broad classification is primary, where the cause is not known, and secondary causes are also there related to trauma or surgery on brain, intracranial tumor, cerebrovascular accident, tuberculoma, cysticercosis. Treatment of epilepsy is symptomatic and the same irrespective of primary or secondary epilepsy. Now coming to the types of epilepsy, কি types হয়? Epilepsy can be number 1 generalized seizure or partial seizure. Now partial আর generalized seizure মধ্যে তফাৎটা কি আছে? Partial seizure এ একটা specific body part will be affected, while generalized it involves the whole of the body. So in simple partial seizure, a focal part of the body is affected and the consciousness is preserved. In the complex partial seizure, focal part of the body will be involved and there will be loss of consciousness. Simple partial or complex partial seizure with secondarily generalization, এখানে একটা focal part of the body involved হবে, gradually whole of the body ধরে নেবে. Now generalized seizure, it includes generalized tonic-clonic seizure, commonly seen. Absence seizure, absence seizure কি হয়? Absence seizure it is commonly seen in children. কয়েক সেকেন্ডের জন্য পেশেন্ট কিন্তু একটক তাকিয়ে থাকে, পেশেন্ট does not remember the episode, কথা বলছে থেমে গেল আবার কথা বলতে আরম্ভ করলো. That is the manifestation in absence seizure. A tonic seizure, হঠাৎ টোনটা কমে যাওয়ার জন্য পড়ে যাওয়া. Myoclonic seizure and infantile spasm. Now the anti-epileptic drugs available, it include barbiturate like phenobarbital, deoxybarbiturate that is primidone, hydantoin. It includes phenytoin and phosphenytoin. Immunostilbene include carbamazepine, oxcarbazepine, succinimide that include ethosuximide, aliphatic carboxylic acid that include valproic acid, divalproics, benzodiazepines that include clonazepam, clobazam, diazepam and lorazepam, phenyltrazine include lamotrigine, cyclic GABA analogs that include gabapentin, and pregabalin newer drugs that include topiramate, jonisamide, levetiracetam, vigabatrin, tiagabine and lacosamide. Now these are the chemical structure of some of the anti-epileptic drugs. Is the structure of barbiturate, hydantoin and succinimide, more or less closely related. Now how the anti-epileptic drugs are acting? Primarily three pathways are there. Number one, they may act on the sodium channel. Now sodium channel, they are present in three states. One is the open state, in which in the presence of the electrical stimulus, the channel gets open and sodium influx occur. So that is the open state of sodium channel. Now after the sodium channel conductance has occurred, the electrical stimulus has stopped, then it turns into inactivated stage. What happens here? যতটা stimulus দেওয়া হোক না কেন, sodium channel will not open up. Now from the inactivated stage, it goes to closed state, sodium channel. Here the sodium channel is sodium conduction is not occurring, but in presence of stimulus, the sodium channel has the capacity to open up. And then from the closed state, in presence of stimulus, it again turns into the open state. Now what does anti-epileptic drugs do? They block the inactivated state of sodium channel and prolongs the inactivated state. That is one of the mechanism by which anti-epileptic drugs are acting. So prolongation of sodium channel inactivation like Phenytoin, Carbamazepine, Valproic, Lamotrigine, Topiramate, Zonisamide, Lacosamide. Second mechanism, by facilitating GABA mediated chloride channel opening. That is done by barbiturate, benzodiazepines, vigabatrin, valproate, gabapentin and tiagabine. And finally, some anti-epileptic drugs, they block T type of calcium channels, and these drugs are more effective in basically absence seizure. That include Ethosuximide, Valproate and Zonisamide. Now coming to the drugs one by one. Phenobarbital. Phenobarbital was previously used to control epilepsy, not used nowadays because of prominent side effects. So first efficacious anti-epileptic introduced in 1912. How they are acting? They basically act primarily at the GABA benzodiazepine receptor chloride channel complex. So already তোমাদের sedative hypnotic করা হয়েছে, হ্যাঁ? So they primarily act at the GABA benzodiazepine receptor chloride channel complex. They potentiate GABAergic inhibition by increasing the chloride conductance and by increasing the lifetime of chloride channel opening induced by GABA. They has specific anti-conversion activity which is not entirely dependent on general CNS depression. Now wide spectrum of anti-conversion property, they raises the seizure threshold as well as limit spread and suppresses kindle seizure. What do we mean by kindle seizure? Basically they are different animal experimental models by which the drugs are tested on the animals. That include number one, maximal electroshock seizure. এটা একটা মডেল রয়েছে, এখানে রডেন্টসের উপরে হাই ফ্রিকোয়েন্সি ইলেকট্রিক্যাল ডিসচার্জ দিয়ে একটা এপিলেপটিক মডেল তৈরি করা হয়। নেক্সট রয়েছে পিটিজেড, ইনডিউস সিজার মডেল। একটা রয়েছে কমপ্লেক্স পার্সিয়াল সিজার মডেল। and lastly রয়েছে কিন্ডল সিজার মডেল। এখানে স্মল ইলেকট্রিক্যাল ডিসচার্জ, স্মল ফ্রিকোয়েন্সি ইলেকট্রিক্যাল ডিসচার্জ রিকারেন্টলি দেওয়া হয়। নাও so basically it has been found that phenobarbital they also suppresses kindle seizure. With continued use, sedation wanes off but anti-convulsant property maintains. Slow oral absorption, plasma half-life 80 to 120 hours, metabolized in liver as well as excreted unchanged by kidney. Steady state concentration are reached after 2 to 3 weeks. They competitively inhibit as well as induces phenytoin and imipenem metabolism. So, interaction basically unpredictable. It may increase the level as well as decrease the level of phenytoin. Sodium valproate tends to raise phenobarbital level when given concurrently. Adverse effect, as previously known, sedation is the most prominent side effect of phenobarbital. Long-term administration may lead to behavioral abnormalities, diminution of intelligence, impairment of memory and learning, hyperactivity in children, mental confusion. Uses anticonvulsant, basically used in GTCS, that is generalized tonic-clonic epilepsy, simple partial and complex partial seizure. Infrequently used in children because of adverse effect, because of its dulling and behavioral side effects. May be used parenterally, আগে ইউজ করা হতো, এখন ইউজ করা হয় না. May be used parenterally in status epilepticus. Status epilepticus মানে হ্যাঁ, বেসিক্যালি রয়েছে ইটস অ্যান ইমার্জেন্সি কন্ডিশন. এখানে কিন্তু রিকারেন্ট সিজার হবে বা পারসিস্টেন্ট সিজার উইথ লস অফ প্রিজার্ভ, যেখানে কনসিয়াসনেসটা প্রিজার্ভ করবে না, তাই তো রে? সো may be used parenterally in status epilepticus but response slow to develop. Now primidone. Primidone is a deoxybarbiturate. It is converted in liver to phenobarbital and phenyl ethyl balonamide. Its anti-epileptic activity is mainly due to its active metabolite because its half-life is less than that of its active metabolite. Anti-epileptic efficacy similar to that of phenobarbital and about 1/3 excreted in urine, seldom used now in GTCS and partial epilepsy, mainly as an adjuvant to phenytoin and carbamazepine. Adverse effect similar to that of phenobarbital. Now coming to the phenytoin, one of the commonly used anti-epileptic drug. It is also called basically diphenylhydantoin. It was synthesized in 1908 as a barbiturate analog but withdrawn because of its poor sedative property. Its anti-convulsant activity was tested in 1938 in the newly developed electroshock seizure model, jeta bollam maximal electroshock seizure model. Now with no effect on or prolongation of clonic phase. যেখানে ম্যাক্সিমাল ইলেকট্রোশক মডেলে হাই ফ্রিকোয়েন্সি ইলেকট্রিক্যাল স্টিমুলাস দেওয়া হয় on the brain of rodents and 3 phases occurs. First of all tonic, basically tonic flexion, তারপরে tonic extension, তারপরে clonic convulsion. তো এখানে বেসিক্যালি ক্লোনিক ফেজের উপরে কোনো অ্যাকশন নেই, ম্যাক্সিমাম অ্যাকশনটা থাকে টনিক ফেজের উপরে. It limits spread of seizure activity. Threshold of PTZ conversion is not raised. Now mechanism of action, its main action is at the sodium channel. It prolongs the inactivated state of sodium channel that governs the refractory period of neuron. As a result, high frequency discharges are inhibited with the little effect on the normal low frequency discharge. This effect has not been noted at therapeutic concentration of phenytoin. Now it depresses number 2 presynaptic release of glutamine. Other than action on the sodium channel, it has got action on the basically facilitation of GABA release and also at the level of the basically glutamate. It depresses presynaptic release of glutamate, facilitate GABA release and reduces calcium influx. However, these actions require higher concentration and their contribution to therapeutic response is uncertain. The primary action of phenytoin, the primary mechanism of action of phenytoin is prolongation of inactivation of sodium channel that occurs at therapeutic dose. Other than that, other mechanisms can be there like decreasing the release of glutamine, like in facilitating GABA action and decreasing calcium influx. But these actions are noted at higher concentration of phenytoin and possibly is not the mechanism at therapeutic dose. Therapeutic concentration of phenytoin has no effect on resting membrane potential. Normal synaptic transmission is unimpaired. Now, its ability to selectively suppress high frequency firing confers efficacy in trigeminal neuralgia and cardiac arrhythmia as well. Trigeminal neuralgia mane? Sorry? একটু জোরে বল। হ্যাঁ, ট্রাইজেমিনাল নার্ভ জানি আমরা। ট্রাইজেমিনাল নার্ভ যখন হাইপার অ্যাক্টিভ হয়ে যায়, পেশেন্ট বিকাম মোর সেন্সিটাইজ, একটা টাচ করলেই কিন্তু সিভিয়ার পেন আরম্ভ হয়। দ্যাট ইজ ট্রাইজেমিনাল নিউরালজিয়া। দেয়ার ইজ neuralgic pain along the trigeminal nerve in a very small stimulus. So বিভিন্ন টাইমে কোয়েশ্চেন আসে লাইক we give an antiepileptic drug and ask the use other than epilepsy. Like in the exam you may be asked viva that say the use of phenytoin other than antiepileptic use. Then one of the use is trigeminal neuralgia, cardiac arrhythmia. Right? So its ability to selectively suppress high frequency firing confers efficacy in trigeminal neuralgia and cardiac arrhythmia as well. Drug of choice in trigeminal neuralgia is carbamazepine. Amra asbo pore. Pharmacokinetics, absorption slow, bioavailability of different market preparations may differ. So একটা পেশেন্ট একটা স্পেসিফিক ব্র্যান্ডের উপরে কন্ট্রোল আছে ফেনিটয়েনে, উই শুড নট চেঞ্জ দি ব্র্যান্ড, বিকজ সল্টটা চেঞ্জ হলে কিন্তু ফার্মাকোকাইনেটিক্স চেঞ্জ হতে পারে। Bioavailability of different market preparations may differ. Metabolized in liver by hydroxylation involving CYP2C9 and CYP2C19 by gluconide conjugation. Kinetics of metabolism changes from first order to zero order kinetics with increasing dose. First order kinetics mane বেসিক্যালি যতটা কনসেন্ট্রেশন হবে বাড়াবি সেই প্রপোর্শনেটলি মেটাবলিজমটা বাড়বে। বাট হোয়াট হ্যাপেন্স ইন জিরো অর্ডার, only fixed amount of drug is metabolized irrespective of increasing the dose. So what happens here, kinetics of metabolism is capacity limited in case of phenytoin. So at higher doses, how much we increase the dose of phenytoin, metabolism is just limited, so phenytoin toxicity may be seen. So kinetics of metabolism is capacity limited, changes from first order to zero order over the therapeutic range. As a result, a small increment in dose produces disproportionately high plasma concentration. Plasma half-life 12 to 24 hours at therapeutic levels, but progressively increases to 60 hours when plasma concentration rises above 10 mg per ml, because metabolizing enzymes get saturated. পরীক্ষাতে কোয়েশ্চেন জিজ্ঞাসা করা হয় ড্রাগস শোয়িং জিরো অর্ডার কাইনেটিক্স, তার মধ্যে একটা ফেনিটয়েন আছে, right? Monitoring of plasma concentration is very helpful in adjusting dose. Therapeutic drug monitoring নিয়ে কোশ্চেন আসতে পারে, কোন ড্রাগসের জন্য therapeutic drug monitoring লাগে, তার মধ্যে একটা ফেনিটয়েন আছে। Why? Because of low margin of safety. কেন কি the drug is showing change from first order to zero order kinetics as the dose is increased. Adverse effect, the most common adverse effect is gum hypertrophy. It's the commonest side effect, 20% more seen in the younger population. And how can it be, it occurs due to overgrowth of gingival collagen fibers, and how it can be overcome by maintaining good oral hygiene. Hirsutism can be seen in younger population, coarsening of facial feature, troublesome in young girls, acne. These are the common side effects with the use of phenytoin. Commonest is gum hypertrophy. Hypersensitivity reaction can be seen like rashes, drug-induced lupus, lymphadenopathy, neutropenia, rare but requires discontinuation of therapy. যদি হয় ওষুধটাকে বন্ধ করে দিতে হবে। Megaloblastic anemia and osteomalacia may be noted because they impairs absorption of the folic acid and vitamin D activation. Administered during pregnancy produces fetal Phenytoin syndrome that is characterized by cleft lip, cleft palate, microcephaly and hypoplastic phalanges. It is caused probably by its adenine oxide metabolite. So, this is a young female on Phenytoin therapy. You see, it is a gum hypertrophy that is seen. That is the commonest side effect. Then acne is there, hirsutism is there. Overdose toxicity, যদি বেশি ডোজটা পরে প্রথম ইনভলভ হয় cerebellum. Cerebellar and vestibular manifestations may be seen. So, what can be the symptom? Patient may present with diplopia, with the dizziness, vomiting, ataxia, vertigo, diplopia and nystagmus. Drowsiness, behavioral alteration, mental confusion, hallucination, disorientation and rigidity. Epigastric pain, nausea and vomiting. Intravenous injection may cause local vascular injury. ঠিক আছে, তাই জন্য intimal damage and thrombosis of vein can be seen. Edema and discoloration of injected vein. When it extravasates, tissue necrosis may be seen. Hypotension and cardiac arrhythmia may occur only on intravenous injection. So, continuous ECG monitoring is needed while the drug is intravenously administered. Interaction: Phenytoin is a potent inducer of CYP2C8-9, CYP3A45 isoenzymes. It competitively inhibits CYP2C9 and 19. Phenobarbital, it competitively inhibits the phenytoin metabolism, while by enzyme induction both enhance each other degradation. So, dual effect is there. Number one, phenobarbital is inhibiting phenytoin metabolism. Number two, by enzyme induction phenobarbital phenytoin degradation বাড়িয়ে দিচ্ছে, আবার phenytoin phenobarbital. So, unpredictable overall metabolism. Carbamazepine and phenytoin, they induce each other's metabolism, and valproate, they are displacing phenytoin from protein bound site. Phenytoin is a highly protein bound drug, so it displaces protein bound phenytoin and decreases its metabolism. So, plasma level of phenytoin increases. Chloramphenicol, isoniazid, cimetidine and warfarin, they inhibit phenytoin metabolism, can precipitate its toxicity. Competitively inhibit warfarin metabolism, they induces microsomal enzyme and thus increases the degradation of steroid. So, OCP failure. Sucralfate binds phenytoin in GI tract and decreases its absorption. Uses: number one, generalized tonic-clonic seizure and partial seizures, but it is used only when better standard drug for GTCH and partial seizure, but is used only when newer drugs are not tolerated. Problem with this drug: frequent side effects. Number one, numerous drug interaction. A small increase in dose can lead to marked rise in plasma concentration. And number four, it can exacerbate absence and myoclonic seizures. Now, status epilepticus, phenytoin sodium IV is used only when phosphenytoin is not available. Nowadays, when in a patient to control status epilepticus, previously we used to give phenytoin. Now, today phenytoin is not used, phosphenytoin is preferred because they cause lesser local vascular injury. Trigeminal neuralgia is one of the non-anti-epileptic use of phenytoin. Trigeminal neuralgia, second choice drug to carbamazepine. So, drug of choice in trigeminal neuralgia, carbamazepine, but phenytoin may also be used. Phosphenytoin is the water soluble prodrug of phenytoin, introduced to overcome difficulties in IV administration of phenytoin replaced phenytoin in status epilepticus. এখন status epilepticus patient আসলে ড্রাগটা আমরা first phenytoin দিই, but when first phenytoin is not available, then phenytoin can be given. Rapidly converted to phenytoin and doses are expressed as phenytoin equivalent. Less damaging to intima, only minor vascular complications are produced and it can be administered at a faster rate. Phenytoin আমরা administer করতে পারি maximum 50 mg per minute আর এটাতে 150 mg per minute administer করা যায়, but continuous ECG monitoring is needed like that of phenytoin. While phenytoin cannot be injected in a drip of glucose solution, phenytoin के glucose solution drip पे देवा जाए ना, we give in saline infusion, but first phenytoin can be injected with both saline and glucose. तो phenytoin ए mechanism of action टा की आछे? Mechanism of action of phenytoin? Prolongation of inactivated state of sodium channel. This is the main mechanism of action. Other mechanisms are also there, like they are inhibiting presynaptic glutamate release, facilitating GABA action and decreasing the influx of calcium. Now, next রয়েছে uses of phenytoin. কি আছে? Phenytoin is a very common topic. Uses of phenytoin. দেখো যখন ইউজেস অফ ফেনিটয়েন জিজ্ঞাসা করবে মোস্ট কমন ইউজ এপিলেপসি, তো সেটা আগে আসবে। সো ইট ক্যান বি ইউজ ইন জেনারেলাইজড টনিক ক্লোনিক সিজার, ইন দ্য পার্সিয়াল সিজার্স দে ক্যান বি ইউজড। প্রবলেমটা কোথায়? ইট ক্যান এক্সাজারবেট কিন্তু বেসিক্যালি akakinetic and myoclonic seizures and absence seizures. Now number 2, they can be used in trigeminal neuralgia. আচ্ছা, সাইড এফেক্টস gum hypertrophy, commonly seen in younger patients. How can it be overcome? By maintaining good oral hygiene. Other side effects common? Acne or hirsutism. ফুলটা দেখিয়েছিলাম, hirsutism, acne, coarsening of facial features. So these are the common side effects, right? আচ্ছা, আর ঠিক আছে। আচ্ছা, আরেকটা স্ট্যাটাস এপিলেপটিকাস ইউজ আমি ভুলে গেলাম। হ্যাঁ, ইউজ করা যায় তো? হ্যাঁ, জেনারেলাইজ ইউজ করা যাবে, পার্সিয়াল ইউজ করা যাবে। দে আর কন্ট্রাইন্ডিকেটেড ইন অ্যাবসেন্স সিজার, ইন মায়োক্লনিক সিজার, akakinetic সিজার। দে আর নট ইউজ, ইট ক্যান এক্সাজারবেট। ওকে। Carbamazepine, chemically related to imipramine, introduced in 1960 for trigeminal neuralgia. So it was previously introduced only for trigeminal neuralgia, soon became the first line drug for partial seizure as well as GTCS. Pharmacological action resemble those of phenytoin. Action on sodium channel is similar to that of phenytoin, that is prolonging the inactivated state. Exerts lithium like therapeutic effect in mania and bipolar mood disorder. So use other than epilepsy is the mania and bipolar disorder and trigeminal neuralgia. It is also as antidiuretic action because they are probably enhancing ADS action on the renal tubules. Pharmacokinetics, oral absorption slow and variable, 75% plasma protein bound, metabolized in liver by oxidation to an active metabolite 10,11 epoxy carbamazepine, as well as by hydroxylation and conjugation to inactive ones. Is the substrate and inducer of CYP3A4 and CYP2C9. Now, carbamazepine is one of the drug that shows auto induction, মানে it increases its own metabolism when chronically administered. okay, because they are the substrate and inducer of the same enzyme. So initially its plasma half-life is 20 to 40 hours, but decreases to 10 to 20 hours on chronic medication due to auto-induction of metabolism. Adverse effect, the most prominent side effect is neurotoxicity. So dose related neurotoxicity, sedation, dizziness, vertigo, diplopia and ataxia. Use of extended release preparations can overcome this side effect. So use of extended release oral tablets helps to avoid high peaks in plasma concentration and the resultant neurological symptom. Vomiting, diarrhea, worsening of seizures are also seen with higher doses. Acute intoxication can lead to coma, convulsion and cardiovascular collapse. Hypersensitivity reactions are rare but can be seen, include rashes, photosensitivity, hepatitis, lupus-like syndrome, rarely agranulocytosis and aplastic anemia. What as they are potentiating ADH action, water retention and hyponatremia, particularly in the elderly subject. Increased incidence of minor fetal abnormalities, but this teratogenic effect is increased when co-administered with valproic acid. Interaction is an enzyme inducer, can reduce efficacy of haloperidol, oral contraceptive pills, lamotrigine, valproate, topiramate. Metabolism of carbamazepine is induced by phenobarbital, phenytoin and vice versa. Erythromycin, fluoxetine, isoniazid, they inhibit metabolism of carbamazepine. Uses, these are basically most effective drug for complex partial seizure, most effective drug, and is very commonly used for GTCH and simple partial seizure. However, like phenytoin, it can exacerbate myoclonic seizure, absence seizure or kinetic seizure. Drug of choice in trigeminal and related neuralgia, but they are not effective in diabetic neuropathy and other related neuralgias. So, phenytoin, lamotrigine, baclofen, they are less efficacious in trigeminal neuralgia. Gabapentin may be tried, not useful in diabetic, traumatic and other forms of neuropathic pain, and they are used as an alternative to lithium in bipolar mood disorder, in acute mania. Carbamazepine is basically a newer congener of carbamazepine, rapidly converted to an active metabolite that is only glucuronide conjugated but not oxidized. Toxic effects due to epoxide metabolite are avoided. Neurotoxicity less seen. Drug interactions and auto-induction of own metabolism are less marked because of its weak enzyme inducer action. Risk of hepatotoxicity is less marked than that of carbamazepine, but that of hyponatremia is more. Water retention, hyponatremia is more with oxcarbazepine. Indications are same as for carbamazepine. Indication ki ache carbamazepine? Indication of carbamazepine? Is the most effective drug in complex partial seizure. It can be used of generalized. It can be used in generalized tonic-clonic seizure, simple partial seizure, complex partial seizure. Number one. Number two, they are the drug of choice in trigeminal neuralgia. Number three, they are also effective in bipolar mood disorder and in acute mania. So, indications are same as that of carbamazepine, but it may be better tolerated. Dose to dose it is 1.5 times less potent. Now, carbamazepine is an enantiomer prodrug rapidly converted in liver to the same active metabolite as of carbamazepine. Same range of therapeutic and toxic effect, only once daily dosing. Add-on drug for partial seizure with or without generalization, only in adults. Now coming to the next group of drug, ethosuximide. Now ethosuximide is effective in absence seizure. Why? Because they act by inhibiting T type of calcium channels. So Clinically, it is effective only in absence seizure. Primarily, action appears to be exerted on the thalamocortical system, which is involved in the generation of absence seizure. Ethosuximide selectively suppresses T current without affecting other types of calcium or sodium current. Calcium channel ta onek type er hoy. It can be T type, it can be L type, it can be N type and PQ type. Now, ethosuximide is blocking T type of calcium channel. This correlates well with its selective action in absence seizure. Slowly absorbed, metabolized in liver, excreted in urine, plasma half-life 48 hours in adult, 32 hours in children. Dose-related side effects like GI tolerance, tiredness, mood changes, agitation, headache, drowsiness and inability to concentrate. Hypersensitivity reactions like rashes, DLE and blood dyscrasias occur rarely. Use in absence seizure, valproate more commonly used. They are also approved for use in myoclonic seizure. Now next question, drug of choice in absence seizure. It's sodium valproic acid. Although ethosuximide is only used in absence seizure and maybe in myoclonic seizure, and sodium valproic acid is effective in all types of seizure. But if question asked, drug of choice in absence seizure is sodium valproic acid, not ethosuximide. Coming to the next drug, valproic acid. It is the only drug that is effective in all types of seizures, simple, partial and generalized seizures, in absence seizure, in atonic seizure, in myoclonic seizure. So, it is a branched chain aliphatic carboxylic acid with a broad spectrum anticonvulsant action, effective in partial seizure, GTCS, absence, myoclonic and atonic seizure. At anticonvulsant dose, produce little sedation or other central effects. Mechanism of action, various mechanisms are there, like a phenytoin like frequency dependent prolongation of sodium channel inactivation. Number one mechanism. Number two, weak attenuation of calcium mediated T current. So, it is effective in also absence seizure, ethosuximide like. Enhanced release of inhibitory transmitter GABA due to inhibition of its degradation, as well as probably increasing its synthesis from glutamic acid. And lastly, blockade of excitatory NMDA type of glutamate receptors. These are the four mechanisms by which valproate is acting as an anti-epileptic drug. Pharmacokinetics, oral absorption good, 90% plasma protein bound, completely metabolized in liver mainly by CYP2C9 and CYP2C19. Some metabolites are active and glucuronide conjugation and then is excreted in urine. Plasma half-life 10 to 15 hours, anti-convulsant actions are longer lasting. Adverse effect. Adverse effect number one, GI side effects are there like anorexia, nausea, vomiting, loose motion may occur, drowsiness, ataxia, tremor occur at high dose. However, cognitive and behavioral effects are not prominent. Patient may complain of alopecia, loss of hair, curling of hair and weight gain. Now, increased bleeding tendency may be seen, rashes, thrombocytopenia are infrequent, hypersensitivity phenomenon, and the most important toxicity is hepatotoxicity. So, asymptomatic rise in serum transamine is often noted. So, monitoring of liver function test is necessary when the drug is continued, and even fulminant hepatic failure occur in children below 3 years. So, it should be avoided in those age groups. During pregnancy, spina bifida and other neural tube defects can be seen in the offspring. So, it should be avoided. Uses drug of choice for absence seizure, right? One of the first line drug for partial seizure and GTCS. Most effective drug for myoclonic seizure. It is also useful in atonic seizure in which response is often incomplete, but valproate is a drug of choice. So, valproate is a drug of choice in absence seizure, in myoclonic seizure and in basically atonic seizure, very commonly used as an alternative to lithium in mania and bipolar illness. So, one of the non-anti-epileptic use of sodium valproate. It has also been used for panic attack. So mania, bipolar mood disorder, in panic attack it is also used. It has some prophylactic efficacy in migraine. Migraine মানে ক্লাস তো হয়েছে, মাইগ্রেনের ক্লাস হয়েছে তো, অটোকয়েডস হয়েছে। তো মাইগ্রেনে আমরা যখন থেরাপি ভাবি দুটো গ্রুপে ভাবি, তো একটা ট্রিটমেন্ট অফ অ্যাকিউট অ্যাটাক অফ মাইগ্রেন, একটা ট্রিটমেন্ট ফর প্রোফাইল্যাক্সিস অফ মাইগ্রেন। So it is one of the drug that is used for prophylactic therapy of migraine. Interaction: increased plasma level of phenobarbital lamotrigine, displaces phenytoin from protein binding site and decreases its metabolism. So phenytoin level, unbound phenytoin level may increase. Inhibit hydrolysis of active epoxide metabolite of carbamazepine. Concurrent administration of sodium valproic acid and clobazam may precipitate absence seizure, so avoided. Fetal abnormalities are more common if valproic acid and carbamazepine are co-administered. Divalproix is basically a combination of sodium valproic acid and with sodium valproate in a concentration of 1:1. Oral absorption slower but same bioavailability. Gastric tolerability is better, and these drugs are more used for bipolar mood disorder than in case of epilepsy. Coming to the next group of drug, clonazepam. It's a benzodiazepine. They act on the benzodiazepine chloride channel complex. So it's a benzodiazepine with anticonvulsant property. They potentiate GABA induced chloride channel influx to produce sedation, and the same mechanism has been responsible for its anticonvulsant property, but the locus of action on brain may be different. Pharmacokinetics: oral absorption good, 85% plasma protein bound, completely metabolized in liver, excreted in urine. Half-life 24 hours, conferring long duration of action. Most prominent side effect: benzodiazepine, most prominent side effect sedation. So sedation and dullness are the most important side effects, minimized by starting at a lower dose and gradually building up the dose. Lack of tolerance, some tolerance develops to chronic therapy. Lack of concentration, irritability, temper and other behavioral abnormalities may occur in children. Motor disturbances and ataxia are dose related side effects. Salivation and increased respiratory secretions may be seen. Usage primarily employed in absence seizure. Also used as an adjunct in myoclonic seizure and akinetic epilepsy, but may afford some benefit in infantile spasm. Value limited by the development of tolerance to the therapeutic effect within 6 months or so. So drugটা 6 মাস পর থেকে কিন্তু এফেক্টটা কমে যায়। Also used to suppress acute mania. Clobazam. Clobazam is basically 1,5-benzodiazepine. They are found to possess useful anti-epileptic efficacy in partial, secondarily generalized tonic-clonic seizure as well as absence seizure or tonic seizure, including some refractory cases also. Side effect profile similar to that of benzodiazepine: sedation, dullness, motor incoordination and others. Sedation and psychomotor retardation less prominent. Appears to act by facilitating GABA action like that of other benzodiazepines. Oral bioavailability 90%, elimination half-life 18 hours, active metabolite is produced having longer half-life. Useful as an adjuvant to other anti-epileptic drugs. Coming to diazepam. Diazepam is used to control status epilepticus. একটা status epilepticus patient আসলে emergency seizure control করতে হবে. So for emergency control these drugs are not effective. For emergency control benzodiazepines are effective drug of choice. Of them diazepam and lorazepam are used, and nowadays lorazepam is preferred over diazepam. So diazepam is the first line drug for emergency control of convulsion, for example status epilepticus, tetanus, eclampsia and convulsion drug poisoning. Not used for long term therapy of epilepsy because of prominent sedative action, development of tolerance. Thrombophlebitis of the injected vein occurs, which is very common. Marked fall in blood pressure and respiratory depression can be seen. Resuscitative measures should be kept at hand before the drug is injected. And number 2, in case of febrile convulsion মানে কি হয়? Do you know? Generally it is seen in children of the age group of 1 to 5 years, where due to fever, high grade fever, the seizure occurs. There is no instructional abnormality in the brain. So in case of febrile convulsion, per rectal instillation of diazepam is the drug of choice. So rectal instillation of diazepam is now the preferred therapy for febrile convulsion in children. Lorazepam is better suited than diazepam in status epilepticus or for emergency control of convulsion. Why? Number 1, because of lesser local thrombophlebitic complications. Number 1. Number 2, more sustained action because than that of diazepam, which is rapidly redistributed. Okay. So drug of choice in status epilepticus, lorazepam. Why lorazepam is preferred over diazepam in status epilepticus? Lesser local thrombophlebitic action. Number 1. Number 2, more sustained action.